And with that, I think we'll turn the floor over to Ayesha for five minutes.
Great, thank you, Josh. So let me just share my screen. Zoom is warning me that my internet is unstable. So just, you know, if you can't hear me or see my screen, just let me know. So I will actually talk about COVID, even though I know Josh said we're going to have more non-COVID work in the fall, brown bags, hopefully. But I just wanted to talk a little bit about work that I've been doing March for pretty much primarily focused on Bangladesh's COVID response. So very much driven by response efforts and not necessarily research efforts. And so some of the tools and methods I'll talk about are and you'll see as I talk about it, very much response focused. But what I do want to do is turn a little bit to research. And so that's where I would love help from students, if anyone wants to get involved. So I'll talk a little bit about opportunities in the end. So just a very quick background, March, and there's been around 300,000 cases to date. And you can see that at the very beginning of the outbreak, so from March until the middle-ish of April, there really wasn't very much testing happening, which is reflected in these confirmed case counts. So there's only one lab in Dhaka that was responsible for all of the testing in the whole country, and the government hadn't really extended permission to other labs for testing. And so there's a lot of uncertainty about the scale of the outbreak and whether it had spread from Dhaka, the capital, to other parts of the country. So one of the things that the government, and this is led by the governmental organization in Bangladesh, lab and hospital-based diagnostics. Even in the best circumstances, there's a lot of delays in processing, and there's sort of huge barriers in ramping up the capacity for testing that's needed. So the idea is to put together this self-reported syndromic surveillance system to capture information about symptoms that are specific to COVID, and to get a sense, a few different hotlines that were set up. People could also use apps and a variety of apps to report their symptoms. And then there were also community field workers who were following up with people who reported symptoms on these calls. So there's two steps. So one, in the first step, people can call, report symptoms, and they can request to a doctor. And so a lot of these calls are then talking to the person on whether or not they think this is actually a COVID case. So self-reported syndromic data, it's been used in the past primarily for flu, but also a little bit for dengue and other diseases. There's a lot of noise in these data sources, and for COVID, the symptoms of COVID are not specific enough to have a super reliable self-reporting system. But the idea was, in the absence of pretty much any testing in places outside of Dhaka, maybe this could give us some signal of where cases are, particularly for the subset of calls that are forwarded to doctors, and the doctor can make a judgment. So this is all work that was led by folks at A2I, and then also been working with Caroline Bucky at Harvard. So there's a lot of people who call different platforms, and you can imagine this data is inherently noisy, and there's a whole range of biases in who's likely to call into these systems. And at the start of the outbreak, the degree to which people knew about the existence of the system, and also about the symptoms of COVID. And also, as I mentioned, given the lack of specificity of some of the main symptoms of COVID, you might imagine that there might also be a lot of people calling in and reporting symptoms who have some other disease. So the idea was to try and think of a simple way to use this data as a tool for monitoring the spread of COVID in Bangladesh. And so we did some very simple things to sort of figure out if there was any signal in the data. So this is just looking at the time series. So spot A is showing for which we have reliable, as reliable as you can get with COVID confirmed case data. But this is April 15th, is roughly when they had really ramped up testing and there was more testing happening from across the country. And then panel B and C are showing the self-reported syndromic data. So B is people calling in and reporting symptoms, and then C is of being high risk of COVID. So you can see there's a lot of volatility in this use of the system. There's these two dips that happen. That's the major Eid holidays where there's very little use of this self-reporting symptom system. And what we did is we looked at how does this self-reported data correlate with confirmed cases at the upazila level. So the upazilas are equivalent to, I think, counties in the US. So each dot in the scatter plot is a different upazila. And I'm just showing this for the 2 weeks in June. So just going back in this time series, the last 2 weeks of this time series. So you can see that there is some correlation in the data with the confirmed cases. And we also see this correlation at 1 week and 2 week lag. So this really helped us sort of, we also did this a little bit more systematically to look at the whole time series and not just correlations at one snapshot in time. And we do see the largest correlation of the self-reported data and the confirmed cases at the current time period, but also at 1 and 2 week lags. And what we did is we set up a very simple dashboard. We still think we don't want to just rely on the self-reported data, so we combine it with information on test positivity rate, which is what many states in the US are using now to decide whether or not to reopen. And so we created a very simple index that sort of lists upazilas as being high priority or low priority for amping up mask use and ensuring that hospitals have adequate capacity. So the other thing that the Ministry of Health was really interested in is understanding the spatial spread, and particularly at the start of the outbreak when there was very little information coming in from parts of Bangladesh outside Dhaka city. So what we did is we partnered with the 4 mobile phone operators in Bangladesh, and they have been giving us data. Highlighting one place here as an example of what we've been doing with this data. So Narayanganj is where some of the first reported cases were, or the first cases were reported. And this this particular region is important because there's a lot of garments factories in Narayanganj. So there's a lot of movement of people in and out of this area. And in this map, the red dots are showing the first high risk, or the case that was deemed high risk on March 29th. This is through the syndromic data. And then the first confirmed case on April 7th. And you can see in this time series plot, this is the volume of people moving out of Narayanganj every day. And you can see that in the map, they're pretty much going everywhere. So this is in a log scale to make it easier to compare places. But you can see that in Narayanganj and people going everywhere. And so we used this data at the very start of the outbreak to come up with maps of where we think the predicted importation was happening from Dhaka city. And we've done, since then, we've gone back and we've looked at at the very start of the outbreak and where we predicted importations to be happening. And because there was no testing, we didn't really know, we can't confirm whether our predictions were correct, but we can look at the syndromic data, and there does seem to be at least some correlation with where people were reporting symptoms and where we predicted the outbreak had spread from Dhaka. And this is, I sort of wanted to show this as the last slide to go back to what I presented, I think back in April, where we were really worried about the major where most people travel out of the city and go to across the country. The heat map is showing where people are going to. You can see the two spikes, those are the Eid holidays. And so back in April, we were really worried about the first Eid holiday. And this is something that I think we put together overnight, and actually the slide basically to try and convince the government that they should enforce a population model to show what would happen if they did enforce lockdown versus if Eid travel was allowed to happen regularly. So thankfully, they did actually impose restrictions for travel for Eid, so we didn't see as large of a spike in cases outside of Dhaka as we would have, I think, otherwise. So that's just a quick update on what I had talked about way back in April. And just in terms of looking forward, there's many different things happening related to the COVID response in Bangladesh. And I think if students wanted to get involved, there's many things that it would be great to have some help on. So we're continuing to look at the syndromic surveillance data and the mobility data and continuing to use it for the COVID response, particularly as we're moving into the phase where the outbreak in Dhaka seems to be declining, but going up in other places. But we're doing a bunch of other things. I won't go into the details of any of this, but if you're interested in any of it, please feel free to get in touch. And then I just want to end by thanking all the folks that have sort of put tons and tons of time and effort into doing all this work. And I'm gonna stop there, and hopefully I didn't go too much over time.
Thanks so much, Ayesha. So we did go a little long, but let me just ask the one question that is in the chat room right now, and that is about, from Don Tryman, what fraction of serious cases is actually hospitalized given the presumably low level of bed availability?
So that's a really great question, and we've been trying really hard to get hospital data. It's really, I mean, even the fact that we got any of this data is sort of remarkable, but it's really hard to get hospital data. What I think what's happening right now is, and the Gates Foundation is funding this, people are going in and digitizing some of the hospital data. So I honestly don't have a great sense of the hospitalization or even death rates. So still very much an open question.
Oh. Lost Josh.
Josh, you're muted. I think he's just muted.
So thank you so much, Ayesha. I'll clap for everyone. Thank you. Kind of like a certain convention, right? One person clapping. And now we're on to Dennis.
Great. Thank you. Thank you very much. I'll try to be fairly fast. I'm gonna start sharing my screen here. Can everybody see my screen?
Me, not yet, but I may be the only one.
Got it. There you go. No, that should be
Now,
great. Excellent. Thank you. So I'm gonna, I kind of wanted to talk about the project I'm working on that is newest and that is most able to incorporate other folks who are interested in it. So I'm going to give an update on the interpersonal contact study that I gave a really quick talk about in the spring. And this is something I've been working on with Ayesha and a few other people that I'll mention at the end of the project. So I think some of you may have seen the talk earlier, but just to give you some quick background, we've been conducting surveys to try and quantify the extent to which there has been a reduction in interpersonal contact during the course of the COVID-19 pandemic. We have a national sample and samples from 6 specific cities. We asked the survey respondent questions about herself, and also questions about her contacts, the context of those contacts, and some other factors like whether or not they use masks, how much traveling they've been doing, and that kind of thing. We've collected 3 waves of data so far, and I'm going to show you I'm going to show you kind of all three waves here. The pilot was in kind of late March, early April. The next wave, that should say wave 1, I'm sorry, was sort of mid-April, and then the second wave was in June. And all told, there's about 6,500 interviews across the 3 waves. The goal of this information is both to help improve the parameterization of models by adding information about age-structured contacts, and then also to help give us some sense of how much people are adhering to guidelines of social distancing, and what sort of folks are most at risk to exposure to COVID through elevated levels of contact. So that's kind of the background here. And I thought to kind of explain the content of the survey a little better, it would make sense to just kind of show you some of the results so far. So I'll do that now. This plot shows histograms of the distribution of numbers of reported contacts over the 3 waves, waves 0, 1, and 2. On the left-hand panel, we have all contacts. So this includes people who live in the respondent's household. And then because we think social distancing policies might especially affect non-household contacts, the right-hand column here has results for just non-household contacts. And you can see that as time elapses from pretty much right after the pandemic started to about a month ago, a month and a half ago, we see the kind of distribution of contacts steadily creeping up in both all contacts and non-household contacts. So this plot kind of shows in the top row the reported relationship between survey respondents and their contacts, and then in the bottom row the reported location where the contacts took place. And I think there's a couple of interesting patterns in the top here. As the 3 waves elapse, we see that increasingly people are contacting work colleagues or classmates, family members, and friends. And if we look at locations, we see an increase over the 3 waves in the number of contacts that take place at work, at some kind of store or business, and in someone's home. We kind of also wanted to understand what sort of people had higher or lower contacts. And so this is a relatively simple regression model that's trying to predict the number of contacts that people report by many different factors. The blue dots here are estimated coefficients for all contacts, and the yellow dots are estimated coefficients just for non-household contacts. This is a negative binomial model, and so kind of estimated coefficients lower than 0 imply fewer contacts on average than the reference category, and estimated coefficients above 0 imply more contacts on average in the reference category. A few different patterns stand out here. Oh, and I should say this pattern with household size for all contacts is not as interesting as it might seem, because that's a kind of mechanical relationship, because everybody in the household is counted as a contact in the way that we're counting all contacts here. But outside of that, there are some interesting relationships here. We see that older folks tend to have on average lower contacts than other age groups. Males have elevated contacts. Respondents who were in Boston or New York had significantly lower contacts than the national sample. Black and Hispanic respondents reported somewhat higher contacts on average. And then you can see here that over time, we see a distinctive increase in the level of contacts, which is consistent with those histograms we saw before. So what implications might this have for disease transmission? This figure is a little bit busy, but it's trying to summarize an answer to that question. So on the left-hand panel here, we have the estimated rate of interaction between different age groups over the 3 waves, starting from the pilot wave at the top down to the last wave in the bottom. This middle panel here shows the difference between these matrices in a kind of baseline scenario. And the right-hand column just shows the age distribution of average numbers of contacts between a baseline and our study. And you can use these matrices to do some calculations to try and understand what kind of difference these levels of contacts would make on disease transmission. And so this figure summarizes our efforts to do that. And you can see that, so this is showing an estimate of R0, the the basic reproduction ratio for the pathogen over the 3 waves, and you can see that the contacts imply a steadily increasing R0 over the time period that we're looking at. So just to give you a sense of where we're going with this, Casey Vrina, grad student here, has been working on using hierarchical models to try and use our data to produce state-specific estimates of age mixing matrices, which is useful because disease models are most useful at the more local level. Taylor Chin is a grad student at Harvard School of Public Health, has been digging into the city-specific data to try and understand disease transmission at the city level. Ethan has started to look, Ethan Rubinoff, a grad student also in demography, has started to look at the relationship, or started to think about the relationship between work and risk through contacts. We're also interested in using these estimates to compare reported contact levels to movement estimates from social media data, and there's a lot of other possibilities too. So if you're interested, please reach out to me or to Ayesha, and we'd love to get you involved. Thanks.
Great, thank you, Dennis. We have a couple of questions in the chat. The first is from Robert Shell. Are the data between different contacts linked? Are you able to determine how many people an individual's contacts have also been in contact with?
No, that's a good question. We have not. So in other words, if I report being contacted to 2 people, do I know if those 2 people have been in contact? No, we don't ask. We don't ask any questions about that. That would be an interesting thing to try to add. Although it would make the instrument considerably more complicated, but we unfortunately don't have information about that.
And one question from Ron, or thing to look into from Ron, to compare contacts by age, et cetera, to serological estimates of infection, also by age patterns.
Great idea, really interesting. That's a very good idea. We should definitely do that.
Okay, that's all from the chat. Thanks, Dennis.
Great, thank you so much.
Okay, so I think I am next. This is Josh. Let's see if I can. Okay, well, thanks so much for inviting me, Josh. It's an honor to be here. I'm just going to talk about one ongoing project, and that is the Census mortality project. This is a screenshot from our webpage, and we see the heart of the project, which is we have census records from 1940, and we have Social Security records, including applications and death records of people when they are older, usually after 1940. And so this project is a study where we are producing linked data, and we're doing research with it. The features of Census is that this is individual level. It's using public data. It's administrative data. It's very large. We have millions and millions of people. And the idea is that we can kind of look at mortality disparities by all kinds of demographic characteristics and more. The inspiration for this project began in a human mortality database meeting at PAA when Magali was talking about new directions for HMD. And I said, well, wouldn't it be neat to have individual level data? And they said, sure it would. And why don't you go do it? So that was the inspiration. Thank you, Magali. So what is Census? Well, we have a team of people. We have, Dennis is also working on this. So we have a couple faculty, we have a bunch of graduate students, and we also have researchers. We're producing public individual level data. The data we release is anonymous, but we have all the people's names, and you can get access to that if you want. The idea is that the power of the big data is it gives us a microscope. We get high resolution into disparities in mortality. We can compare small groups for which previous studies haven't been able to produce reliable estimates. We can look at new patterns that give us new insights into the nature of what is causing people to live longer or shorter lives. There are some technical challenges with the project, which we're all working hard on. One is simply to match the records. It's easy to match most cases, but the small number that you can't match take a lot of time and energy and thought. And then we also have developing some new demographic methods. We don't have survivors because we only have people who have died in the Social Security record. Those are the records that have been released. So we need new methods for estimating mortality. We're currently doing research on, and I'll present a little bit of this. I presented about immigrants, I think a year or two ago. Education, I'll show a slide from racial disparities. I'll show a slide from certain angle on that. And there's lots of opportunities for work with this. You can do spatial analysis. You have potential to get exact street addresses. Of course, early life conditions, looking at outcomes for children observed in 1940, occupational detail, gender, we've matched women, new female sample. Housing, there's amazing things you can also do with environmental conditions because you know people's addresses, you know how much lead, you can estimate how much lead was in the water, things like that, relationship to pollution, all that kind of thing. So I'll just show you two examples now of things that are underway. The first is what we call the educational staircase. So for longevity, these numbers are kind of relative to some baseline, how much longer you live, I think conditional living till 65. And you see that people with 17 years of education live 2 years longer than 0, and people with elementary school education live a little bit less than the average person, 0. And what is notable about this is that, see, these bars here are kind of confidence intervals, is that our confidence intervals are small enough, which is not true in previous studies, that this is not kind of a straight line, which is what previous studies have seen. Instead, it's a kind of a staircase. There's steps. And the steps are when you finish school. 8th grade is a finishing school, 12th grade is finishing school, 16th grade, that's finishing college. And what we find remarkable is not so much the big step here, but rather the lack of progress for being in school. Simply spending more time in the classroom does not seem to bring you anything in terms of longevity. But being a person who finishes school has a big effect. So the reason we're interested in this is trying to get a handle on the causal effects of schooling. And this kind of figure at least points me in a direction that makes me think that maybe schooling is not conferring much. Maybe there are different types of people, and the people who can have the resources or stick-to-itiveness to finish their schooling are also the kind of people who may live longer, maybe because the habits you need to get something done in school or the resources you have are similar to the habits and resources you need to kind of invest in your own health and take care of yourself. So this pattern we do not see for earnings. So if this is a staircase, the pattern for earnings is a slide. Here we have log earnings. And so there's certainly, there's a bonus from graduating from high school, but there's also a lot, going from 9th to 10th grade helps you. Going from 1 year of college to 2 years of college helps you. The standard errors here are so small you can't even see them. So these are not sheepskin effects kind of in the labor market. There's something else. And so this is a project I'm working on with Ryan Edwards, and we're trying to figure out what's going on. Our suspicion is that, there's also kind of a staircase in smoking behavior. And that seems to be the one kind of signal that we seem to have found that has a similar pattern. But the point is that because of these enormous sample sizes, we can see new patterns that were not visible before. And here's just a second example. So I think I've given talks to this group before about names. This is a picture kind of bringing together names and longevity. This is work with my former Berkeley classmate and off-time collaborator, Guy Steklov, and also Casey has just joined this project and is helping us advance quickly. So we call this My Brother Moses because we are looking at African Americans who are brothers and looking at how much their name influences how long they live. And specifically, our question we're asking is if you are given a more distinctly African American name, then are you treated differently in life, and do you have a different life outcome? And this slide is actually cross-sectional, but it's similar to what we do when we do our within sibling analysis. And what we find is that, in fact, even among brothers, if you're given a very African-American name, like Cleveland or Roosevelt or Booker, then that's to the right, the very common African-American names, and the names that are more common among whites, Donald, Kenneth, Ralph, Francis, Anthony, tend to live a little bit longer. So it's about a year in life between having a very African-American name and a very non-African-American name. And I think that's about halved when we do the sibling fixed effects. And our interpretation of this is that even in these are cohorts, I think cohorts of about 1910, people dying in the 1980s, 90s, 2000s. Our interpretation is that even in this time, this is before filing a lot of things electronically and all this, even when people are meeting you and you're self-identified as African-American, that somehow you're being treated differently if you're considered more African-American or less African-American. So we're kind of we're somehow looking at this gradient. Now this gradient is much less steep, of course, than the difference between, say, blacks and whites, and that's the other thing we're trying to quantify and trying to figure out where this is happening. Is it in schooling? Is it in the labor market? It could be treatment in the medical system. We're trying to figure that out. Okay. So what are the opportunities? Well, you can just be a Census user. You can download the data right now. You can use it for your dissertation, a class paper, your research. We have support from NIH, National Institute for Aging. We have money to hire people. If you have a project you want to do, we can probably even pay you to do the project. But we're also hiring people to help us produce the data and develop the methods needed to do analysis with the data. If you're a researcher that is working with other microdata, you can probably link your microdata to the Census data. If you have names, we have names. If you have social security numbers, we have social security numbers. If you have place of birth, we have that. And an example of this that's on our agenda is the World War II military enlistment records with height and weight, and also some IQ scores are available, and we'll hope to link that to Census. So here is the project link, which will bring you to the live version of this picture. And I'm all done.
Great, thank you, Josh. We have two questions in the chat. The first is from David on education and longevity. Wouldn't it be more immediate to suggest that longevity is increased by career and earnings advantages that come from a degree? Even stratifying by earnings, the career paths are going to be very different.
Something we can look at. I don't know about the logic of it. I'm putting a little bit on the spot here, but we can certainly look to see whether the distinction is occupational as opposed to financial. Financial was easy to look at because we have those earnings records. Occupation is a little more tricky, but I wouldn't be surprised if occupations are quite different for people who finish their schooling. Again, whether that's a mediating mechanism or whether that's just kind of a correlate, I don't know, but excellent suggestion.
Great, and one from Magali. Do you control by year of birth in the relationship between name and longevity?
Yes, when one uses this data, you always need to control for date of birth because we only see a narrow period of deaths, not necessarily narrow, a certain period of deaths. So people born earlier die at later ages, and people born later die at younger ages. So you need to control for that. And so that's something you have to do in all the mortality analysis. And it's also important for, clearly with naming, where there are trends in names, you want to take that out. So yes, that is something that we do, that you must do, and that we also do for this study.
Great. Thank you, Josh. That's all from the chat.
Thank you so much. Now I revert to being moderator. Our next speaker is Will Dow.
Great, thank you so much, Josh. I'm going to share my screen, I hope, momentarily.
Warning to the group, we only have 15 minutes till 1, so we're definitely going to go over. So try to rearrange your calendar and stay for Ron and Ken's talk. We're going to probably go till 1:15.
Okay, great. So can you see my screen now?
Yes.
Okay, you see a slideshow? Great. So I'm going to be very brief because I want to give sufficient time for Ron and Ken, and just take the spirit of these are just very brief advertisements about things that I'm doing. And so I'm not going to give any details really. So I want to talk about 3 things, just some quick CEDA updates, talk about some COVID-19 projects that I'm doing, and then a new sort of survey project that I'm doing in the Caribbean. So first of all, CEDA, I think most of you are familiar with, the Center on the Economics and Demography of Aging that Ron Lee started 25 years ago now. CEDA has been renewed by NAA for another 5 years. So that's great news. And Josh introduced at the beginning Maria Hernandez, who's our new center manager. So you'll be hearing from her. The themes are similar to what we've had as themes in the past. The signature themes around mortality measurements, projects like the HMD as signature projects, the macro consequences of global aging, such as the National Transfer Accounts Project, the biodemography of aging work that we'll be hearing more about in the brown bags, and then a whole set of topics more generally around policies and behaviors that shape adult health. But we're always interested in innovative topics outside of these themes as well. So particularly those topics that are related to current things that people are talking about in the fields, whether it's about racial equity, the census, the electoral, political demography, etc. So as always, CEDA is going to continue to support networks, many conferences. So we'd love to hear your proposals for meetings, that kind of thing that you'd like support in pulling together. We have computing support, so Carl Bowe is a key contact there. We support dissemination, so for example, we've been supporting Gretchen Donower and the NTA work, and we've supported GSRs to pull together dissemination around finished projects. Leora Lawton helps out with grant proposals, and then we have pilot projects, which we continue to fund. So we have a current call for pilot proposals out. Those proposals are due October 1st for projects that will be in the first half of the new year. Then we'll have another call for pilots in January for projects that will start next summer. So I do encourage you to contact us if you have ideas for pilots. Okay, a couple of COVID-19 things that I'm doing. First of all, in the sort of public health realm, I've been working on what types of public health investments may have been effective in mitigating some of the worst parts of the pandemic, and one is around PPE stockpiles. So there was a bill in the California State Legislature this summer around PPE stockpiles, and that came to my attention. And so I pulled together a quick and dirty analysis of the cost of creating a stockpile, and it turns out that we would save an awful lot of money if we created a stockpile in advance rather than paying pandemic prices. But what the media has been most interested in and continues to ask me about is how many essential worker deaths could have been averted by a stockpile. And we did some very quick and dirty, back of the envelope types of estimates that suggest, in California, at least 50 or so healthcare worker deaths could have been averted if we had appropriate PPE available. But I would love help if people want to think about how we could better estimate that number, because there's huge public interest in that. The current stockpile bill has passed the California legislature, but there's going to be continued interest in it. So it's a real-time topic that people want to know about. Second, I've been doing work around paid family leave, and we're going to be putting out a new survey very shortly around sick leave in the time of COVID. This is work that's supported by the Robert Wood Johnson Foundation. We have a hub on work and family policy that's going to be active for through the spring, and we have the funds to support rapid response type projects. Again, if you have quick projects that are on very actionable types of items, let me know related to work and family policy and health. And then in Tanzania, where I've been, we were in the middle of a randomized controlled trial with female sex workers to prevent, test strategies to prevent HIV when COVID hit. And so now what we've done is we have a phone survey in the field where we're looking at the effects of COVID on the demand and supply of sex work. And so that's work that will be coming out soon. And then the last thing I wanted to talk about was this Caribbean American Dementia and Aging study that we call CADAS that NIA funded us to begin last year. So we're going to be building on what's called the 1066 Dementia Research Group studies in low and middle income countries that started in 2004. They have multiple waves focused in urban areas. We're focusing in the Caribbean. We'll be collecting new nationally representative household surveys in Dominican Republic, Puerto Rico, and hopefully Cuba, although NIH won't fund the Cuban work, so we're getting more money. So these will be samples, about 1,500 seniors, or adults 65 and over in each of these sites, nationally representative. We're going to be harmonizing with the health and retirement surveys, cognition surveys, so building on our Costa Rican, Crelis work also. And the immediate aims that NIA is funding is to look at the life course determinants of dementia, comparing people who grow up in very different contexts, Hispanics who grow up in the US versus in these sort of Caribbean sites. So that's the overall goal, but it's really very broad multi-purpose surveys that we're doing, very interdisciplinary team. And already Maomei Liu has just received funding for a supplement to look at native versus immigrant racial disparities in cognitive aging. So we would love to have other people who want to join in and add on projects to this. We haven't gone into the field yet. We've been delayed due to COVID. So now's the right time. If you have any interesting questions around Cuba, Puerto Rico, Hispanic immigration among older adults, etc. So I will stop there, and I'd love to hear from folks who want to be involved in any of these.
Thank you, Will. We have a question from Don Tryman. What is the denominator for the 50 deaths?
So the 50 deaths, this is among California healthcare workers, essential healthcare workers. So the state has published numbers that they have 150 healthcare workers in the state who have died from COVID-19. That's a huge undercount. And then we have many other essential workers that aren't counted in that. Some of those are going to be community transmission. Some of those could not have been prevented through PPE, et cetera. And so what we've done is used estimates from all sorts of different literatures to try to back out how many of these deaths may have been workplace transmissions that could have been prevented from adequate PPE.
In the interest of time, I think we should advance right to Ken, because we're running short. There are excellent questions in chat. I hope they'll be followed up by email and other things.
Good. Well, I wanted to speak briefly to keep genetic demography in the spotlight here and talk about ideas in negative heritability and sibling demography. Building on a joint paper with David Steinsaltz at Oxford and Andy Dahl in Chicago that we published in Genetics in June, largely ideas from David, who's on this Zoom seminar today.
And we've lost your screen.
You've lost my screen. Screen is, sorry. What do I do then? Well, stop share and start over.
That sounds like a good idea. It was up a minute ago.
Okay, I think, do you have it now?
We can see it. We can see it.
Good, okay. Now, but how do I go to the next slide then? Oh, here we go, okay. So, very briefly, there's a genetic part and two sides of this story, a genetic part and a demographic part. On the genetic side, individuals are born with genetic propensities, which we can now measure for outcomes like educational attainment. And on the demographic family side, despite being genetically related, siblings within families often differentiate. So one sibling goes out for football, the next one goes into computers or writes poetry. This isn't always true. Two Williams sisters both went out for tennis, but it's true often enough that birth order and family composition do often drive demographic outcomes of differentiation. Some of you may know the book Born to Rebel by our Berkeley colleague Frank Soloway, who seeks to explain the French Revolution, partly in terms of sibling differentiation. So the two sides I'm talking about come together in this topic of negative heritability. And some of you are going to say, negative heritability? There's no such thing. Heritability is positive. It's a ratio of positive quantities. It's additive genetic variance over total variance. But as David pointed out, heritability has another sense, which goes way back to the early days of genetics, sense of a correlation between traits of parents and traits of children, and thus a correlation between genetic relatedness and phenotypic whole person similarity. And it's the second sense that is the one built into the techniques that demographers are now using, the new methods like GCTA and RSMLE and other acronyms you may have heard us working with, and especially the polygenic risk scores that now dominate a lot of sociogenomic work. So within these statistical models, in the second sense of heritability, the heritability parameter can be negative and still meaningful. So in the June genetics paper, we defined a phenotypic repulsion model. And the basic idea is that closely related individuals differ more in their traits than random individuals. And that happens because behaviors in the real world smuggle a non-genetic component into the ostensibly genetic heritability parameter. And it takes some math, again, largely from David, to show this can really happen. Now, our original model in the paper is framed for organisms in general constructing niches for themselves in broadly shared environments. It's not about families. So the next step I'm trying to think about is how to reframe the phenotypic repulsion model on a family basis to look at siblings. And right now there are lots of ad hoc studies of social mobility coming out all the time, featuring polygenic scores and working with parental effects and sibling effects. And we hope to help to make some sense of them.
Thanks so much, Ken. I think we're just going to jump right to Ron, if that's okay, at 1 o'clock. We'll take questions for Ken and Ron afterwards.
Okay, does everybody hear me and see me?
Yeah, maybe you can go to full screen of your.
Yeah, I thought I had. There we go. Okay. All right, you seeing full screen?
Yes.
Oh, okay. So, I'm heavily involved in national transfer accounts, NTA. Will mentioned this project. It's an international project now with research teams in more than 70 countries around the world in all continents. And it's been going on for 18 years now, jointly with Andy Mason. We started it and it's just grown. And Gretchen Dunauer, who I hope is on this Zoom meeting, I don't know, is the newly elected chair of NTA for the next 2 years. And if you're interested in NTA, you can find out more on ntaaccounts.org. But I'm going to talk about a current new direction. There are a number of new directions, but this one is work I've been doing with Gretchen and Andy and others. We're shifting from looking at averages by age or by sex for NTA to looking at inequality measures for the US. And the first way we do that is to construct our basic NTA measures, but do them by educational attainment. And we're also looking at NTA over time within the US, mostly over the last 30 years or so. And for kids, it's by education of household head. And then the second way, which we haven't yet implemented, but we're about to, is to look at individual level distributions. So we can look at distributions of income. I think more interesting will be distributions of consumption. And these can reflect transfers received from within the family, publicly provided transfers, and so on, all of which are part of real world consumption, but will change the amount of inequality and how it changes over time and so on. And for distributions of wealth, of course, we're very familiar with the PPD and Saya Zuckerman work, but it'll be interesting to see how those results change if we include pension wealth. That is, well, I won't go into how that's measured, but it's another concept from MTA or from economics in general. Let me just show some results for the first of these, the way things have changed over time. Here, I'm comparing results for 1988 to results 30 years later for 2018. And this is, in this case, we're looking at labor income by sex. So, and these are standardized on average labor income at ages 30 to 49. Anyway, what you see is here in 1988, males earning much more.
Ron, you're going in and out in terms of the volume. Maybe if you could put your head, try to keep your head in one place.
I'm moving my head too much. Okay.
I can't hear you.
You hear me? Try this then.
Much better, much better.
Okay. So comparing 1988 to 2018, male to female labor income, and you can just visually that there's a big reduction in inequality, and then this is a little measure we've constructed that also shows summarizing across the whole age distribution, the reduction in variability. So that's labor income and diminishing differences by sex. Here we have consumption. Now we're looking at this by education. This is by educational attainment, and then this is by educational attainment quintile. And the quintiles are important because, as we know, there's increasing selectivity of the adverse selectivity of those in the bottom educational attainment and diminished positive selectivity of those in the top. And so you get a very a different kind of measure. One might say a distorted measure when you look at education itself. We focus on quintile. And you can see that there's been an increasing dispersion here, as opposed to labor income by sex. And when we look at our dispersion measures, we see this here as well. But you can see that the increase in dispersion is less when you look at inequality by educational quintile. And then here we have labor income by education and educational quintile. And here you can see an increase in dispersion because, for example, you see a reduction at the lowest education group in labor income. You can see an increase in dispersion by education, and you can see a smaller increase in dispersion by educational quintile. Actually, when you look at these measures, you can see there's almost no increase when you look at it by educational quintile. And then if we look at asset income, let's focus on quintiles. You see, when you look at the quintiles, well, the mean asset income has declined relative to labor income. It's declined over that 30-year period. That might be partly due to the declining interest rates. But nonetheless, what you can't so easily see visually is that the dispersion, in a proportional sense, has increased over that period. And I think that's probably, yeah. So that's what I was going to show you on NTA. We haven't yet done the individual distribution. I wanted to just say a word, one slide on evolutionary demography. Josh mentioned that I've been working on edited volume with Rebecca Sear and Oscar Berger, and we'll be hearing presentations of some of those chapters, and I should say a number of Berkeley and Berkeley-related people like Ken, myself, Jim Carey, who I saw was on the call, Tolja, who probably wasn't on the call, but and maybe some others have papers in this volume, and we'll be hearing from some of them. Okay, now my own research in this area, well, I thought I would just mention briefly the project I'm still working on. I presented this as a brown bag early in 2019, and intermittently I've had a chance to get back to work on this with Cyrus, and I think we've made quite a bit of progress, and I'm now going to put it together in an article to submit. But the basic idea is this is an optimal life history approach. You ask, given a certain set of constraints and so on, what kind of arrangement of fertility, mortality, investment in human capital, body size, whatever, over the lifetime would yield the highest reproductive fitness. So that's the quite mathematical approach we take, but we try to be very concrete in relating this to particular species and to the literature on evolution of, well, particularly sociality, social organization in humans and other species. And we're trying to ask, why are some species social and others not? Why does it take different forms and so on? And in particular, the central question is why in so many social species, many females are non-reproductive. So we suggest that there are returns to scale in production, but also there are returns to scale in reproduction, so that if there are 10 females, you may have more offspring if you devote the same resources to only one reproductive female who's specialized in it, than if you spread those resources across all 10 females who had to both reproduce and be productive. Okay, I'm going to leave it at that. I should mention also, well, Josh and I have done some work on the demography of COVID that came out recently, and we have a project or two that we may or might not get back to, but I'd be very interested to hear from anyone interested to work in any of these projects. Thanks.
Thanks so much, Ron. We have, we're officially at the end of our grace period at 10 past, but we usually go on for a few more minutes. So we have time for a question for Ken and Ron. And while you're typing your questions into chat, I was wondering if I could get Mara on the screen. Mara, can you show your face?
I am.
Yeah, I just wanted to introduce you to everyone. So Mara Loveman has a new joint appointment in demography along with Will, but has been actually arrived on campus the same day I did back in 2013 in the Department of Sociology, and chaired sociology for a number of years, and is our new internal chair as a demography faculty member. So can we see your face? I can't quite see it. Let's see.
Working yet? See it? It's working
Well,
for me.
the fact that I don't see it is okay, but we can all clap and welcome you and wish you luck in your great efforts on all of the department's behalf. So
Thank you.
welcome.
I'm really honored to have the opportunity to chair this amazing department. This was a great set of introductory talks to all of your work. Some of you know that my own work is in the politics of demographic data production, the production of censuses and nationally representative data sets historically and today. And I'm very interested in the politics of that, and also in issues of measurement, demographic measurement of race and ethnicity and demographic and stratification research, and how the way we measure race and ethnicity affects what we think we know about racial and ethnic disparities. So those are some of the ways my sociological interests intersect with these conversations in demography. But basically, I just want to say I'm really excited to be working with all of you, and it's an honor to chair the department.
Thank you, Mara. And Mara agreed to do this before the pandemic started. She, of course, has her hands full. Okay, I'm not seeing any questions in the chat room. I really enjoyed both talks by Ken and Ron, and I don't take that as any indication of lack of interest, but rather the group needs some time to ponder. So let's take advantage of the extra 2 minutes we have just to thank all of our speakers for jumping in the last minute. Next week, we'll have our first full seminar by one person on a non-COVID related topic. That is Professor Leah Bustan from Princeton. Next week. And then I believe the week after, the 16th, will be our first biodemography series. We are rapidly filling up our fall program, but if you really want to present in the fall, please reach out. And then we still have slots in the spring program. One thing I hope to do this year is bring in a number of new faculty on campus, especially assistant professors. We've already got a few for next semester. So that should be great. Oh, and Danya Lagos will be speaking to us this semester. So that will be also a feature of these talks. Thanks everyone for joining in. Please send me feedback on how we can improve these sessions. I thought we can try doing this, 6 talks in 1 hour, and we successfully did do it. So thanks to the audience, thanks to the speakers, and have a great rest of the week, beginning of the school year, and see you next Wednesday. Thanks, everyone.